Welcome to this explainer, where we're going to break down the mechanics of reconstructive surgery. We'll be looking at everything from the biological miracles of tissue survival right down to the precise geometry used in the operating room.
Here is what we're covering today: skin grafting fundamentals, functional area reconstruction, the geometry of Z-plasty, complex facial flap reconstruction, and finally, post-operative flap monitoring. Let's get straight into it.
Section 1. Skin grafting fundamentals, the biological miracle.
Okay, let's kick things off with a foundational question. Up to 48 hours, by which mechanism does a graft actually take nutrition from the recipient bed? Is it fibrin clot formation, imbibition, inosculation, or vessel remodeling?
If you guessed imbibition, you hit the nail on the head. For those first critical 48 hours, the graft survives through plasmatic imbibition. It's wild. It basically acts like a biological sponge, drawing up the host's plasma and nutrients right through a temporary fibrin network. Then, around days 3 to 5, we see inosculation, which is when those primitive connections, often playfully called kissing capillaries, start to form. And finally, true neovascularization kicks in from day 5 onwards. Moving right along, let's think about surgical tools and trade-offs. What would you say is a major disadvantage of using a split-thickness skin graft, or STSG?
The correct answer here is high secondary contraction. You see, split-thickness grafts have a real issue with this. They can contract up to 40% as the wound heals, and that's all driven by myofibroblast activity. Full-thickness grafts, on the other hand, show high primary contraction right off the bat, but they have virtually zero secondary contraction once they're actually placed on the wound bed.
Before we jump to the next section, here's a crucial exam pearl on correcting your STSG harvest depth. If a surgeon notices brisk, large, puncted bleeding points during the harvest, it means they've gone too deep. They've entered the deeper reticular dermis. The immediate next step: decrease the Humby's knife gap thickness using the side dial to get right back into that ideal 0.2 to 0.3 millimeter plane.
Section 2. Functional area reconstruction, restoring mobility.
Let's test this in a highly mobile area. Which of the following is a suitable option to cover a defect on the palmar fingers right after a contracture release?
You definitely want to go with full-thickness skin grafts here. This perfectly illustrates a massive clinical pearl, the hand reconstruction rule. You absolutely must prioritize full-thickness grafts on highly mobile zones to prevent secondary contractures from ruining your surgical result. Never use an STSG on palmar digits because the flexion contracture will just come back. And if you're wondering where to get that full-thickness tissue, your ideal donor sites are the inner upper arm, the antecubital fossa, and the groin crease.
Okay, how about a larger joint? What is the best surgical option to treat a 7-centimeter fixed flexion contracture at the elbow joint when it's surrounded by plenty of normal, healthy skin?
The answer is a YV-plasty. Why? Well, YV-plasties actively advance the surrounding normal skin directly into that contracture zone. By recruiting that adjacent loose tissue, the surgeon can successfully lengthen the tightened area. It's a really elegant solution.
Section 3. The geometry of Z-plasty, surgical mathematics.
So let's talk about the math behind skin movement. A Z-plasty is a type of which of the following flaps? Is it a rotational flap, a distant flap, a transposition flap, or a musculocutaneous flap?
It's a transpositional flap. It literally works by interchanging two adjacent triangular flaps to completely redistribute tension lines. And here's an absolutely essential pearl for you: the angle to gain ratio. While a 90-degree angle mathematically gives you a massive 120% gain in length, it creates far too much mechanical resistance to be practical. The 60-degree configuration? That's your clinical standard right there, granting a super reliable 75% length increase. On the other end, a 30-degree angle yields just a 25% gain, but carries a really high risk of tip necrosis.
Section 4. Complex facial flap reconstruction, the art of the face.
All right, imagine you're reconstructing the most aesthetically sensitive part of the body. What is the most suitable flap option to cover a 2 by 2 centimeter medial canthus defect right after a basal cell carcinoma excision?
You'd want a glabella transposition flap. The medial canthus, right near the inner eye, requires an absolutely exact color and thickness match, which the glabella tissue provides perfectly. Let's look at a few other tactical exam pearls for the face. For a nasal tip defect under 1.5 centimeters, you'll use a bilobed flap to distribute tension without distorting the alar rim. But if you have a large nasal defect over 1.5 centimeters, you're going to need a paramedian forehead axial flap, which is reliably based on the supratrochlear artery.
And here's another pearl regarding composite grafts. Think of a composite graft as a biological puzzle piece. It's a non-vascularized block containing multiple tissue layers, like taking both skin and cartilage from the ear. Since it has no immediate blood supply of its own, its survival relies entirely on that early plasmatic imbibition from the margins we talked about earlier.
Section 5. Post-operative flat monitoring, the critical watch.
Now, picture this high-stakes scenario. You're doing post-op checks, and a replanted digit is pale, cold, and exhibits a delayed capillary refill of more than 2 seconds. What microvascular emergency are you looking at?
That is a classic arterial obstruction. An arterial occlusion blocks the blood inflow entirely, rendering the skin pale and cold with that delayed refill of over 2 seconds and a totally flaccid turgor. Now, as an exam pearl, compare that to venous obstruction, which is actually way more common in free flaps. Venous occlusion traps the blood inside, so the tissue turns cyanotic or violaceous, it stays warm, gets super swollen and tense, and presents with a rapid capillary refill of less than 1 second.
This all leads to our final pearl. Reconstructive monitoring requires incredibly strict, hourly checks of color, refill, turgor, and temperature. Because at the end of the day, reconstructive surgery is a delicate negotiation with the body's vascular system.
So, I'll leave you with this to think about. As our understanding of surgical geometry deepens and microvascular techniques continue to evolve, how close are we to perfectly reconstructing any part of the human body without leaving a single trace of the original defect?